All right. So, all right, ACLS algorithm. So, I'm not going to teach y'all anything today that you probably haven't already seen. So, this is a lovely little ACLS algorithm on the app, which I'll show y'all a picture of at the very end. But basically, we're just going to go through this thing right now and like a situational scenario, and then talk about some other things that this doesn't cover. Just if you're the person that responds to a code, what should you do? So, case-based learning, like I said, y'all cut me off. Anybody on the Zoom end, feel free to chime in at any point. And then the other thing I added on, which I felt maybe more applicable to y'all, especially with cross cover, is cardiac arrhythmias. So I feel like a lot of times when a code happens, people are going to be there quickly to help you. Whereas when a borderline vet patient happens, it's just you at night, or it's you on cross cover. So I feel like going over some arrhythmia situations may be helpful. All right, code blue called overhead. And this is the first thing that comes to your mind. You're like, oh yeah, I know how to run a code. Saw that on the office. Okay, so all right, code's called overhead. Treva comes in, walks in the door.
She runs back out the door. Have to go find someone else.
Okay, so I just want to go through like a real situation. So you walk in, you're on like WA, and you're like, God, this nursing staff is awful. What are we doing? And you just see this nurse and like tech doing some awful compressions, and they're just like staring at you when you walk in the door. So the question I have is going to be, one, when you walk in, just ask who's running the code, establish that it's you. That's one of the biggest parts that I feel like residents and APPs and people struggle with, where it's like, don't be afraid to assert your dominance when you walk into a code, just to make sure the patient gets done for them what needs to be done. And then two, honestly, if y'all take away nothing from the lecture from the code portion, I think this is probably the most important thing you can do, because you may be the first person that shows up there. So I just think of this as the 2-minute drill. When you walk into a code and you see what's going on, you're the person running the code now. Just like list out all the things you would do in the first 2 minutes. Because I just want like collective knowledge here. Like what do you think of? Like, oh, I've got to get this done. This needs to happen.
Pulse check.
Okay, pulse check.
If not already done.
Pads.
Assign the roles. Assign the roles.
Assign the roles. Access.
Confirm their full code.
Yes, that's important. I don't think I put that on here. Yes, definitely do that. Check the consensus.
Find the pharmacist.
Okay. Like that.
Check an airway.
Okay. Airway. Crash
In
cart.
the room.
Crash cart in the room.
We'll get some epi.
Talk to the
Effie's
family
in
about
it, yeah.
DNR, DNI.
Okay. Love that. Okay. So that's good. So first and foremost, always the two most important things are always going to be compressions and epi. Compressions and epi. So just make sure when you walk in, you see somebody doing compressions, make sure they're not doing this like a true compression, like ribs should break if they're doing good enough compressions. And if you ever Doppler somebody's femoral, you should hear a very loud whoosh, whoosh, whoosh if somebody's doing good compressions. So make sure they're doing good compressions, IV access or IO access. The other thing to think about is getting the backboard under the patient, so that way your compressions are a little bit better in quality. And then, just like you said, get the pads and the monitor hooked up, because you want to, make sure we're giving compressions and we're giving epi before the first pulse check, but at the time of the first pulse check, you want to make sure the pads are on so you can shock this patient if you got to shock them. And then, like you said, assign roles. So if y'all can do all of these things when you get to the room, by the time you get to that first pulse check, the med team's probably going to be there for you for backup, for further assistance. So if you do this, you have the best chance of saving this patient's life. All right, we're at pulse check 1 now. This is what you see. And the patient is pulseless. What do we do?
Yeah.
Do we do that?
This is the same lead.
So, okay, sorry. All right, so let's say you can be either one of these. You either see this on the left for people on Zoom. I don't know if you can see, let me do it on here. So you either see this and the patient's pulseless, or you see this, like organized rhythm, and the patient's pulseless. So
Continue compressions, epi.
boom, continue. So on the left-hand side, so this is basically asystole. Right-hand side is PEA. So you got an organized rhythm, can't feel a pulse anywhere. So, like you said, resume compressions, give epi. So to go over epi dosing as you go through the code, it's just, it comes in a little vial in the cart. Basically, it's a 10 ml push. So you can give epi every 3 to 5 minutes. The way I remember this, so let's say you run a code and every time it's like, oh, this patient's in asystole, we're just doing compressions, giving epi. It's every 3 to 5 minutes, but if you do it every 4 minutes, you can almost remember to just do it every time you pulse check, or every other time you pulse check, so that way it's just like in line with do it this round, don't do it next round, do it the next round. That's just an easy way to remember. All right, so do some more compressions. Now we get to the second pulse check. And now you see either this rhythm on the left or this rhythm on the right. And you're like, what do we do now?
Charge 200.
Love it. Okay. Synchronized shock, unsynchronized shock. Defibrillate. I love it. Okay. So yes. So basically this is going to go down the algorithm of pulseless VTAC, which is the left, or VFib, or something that looks kind of like this torsades looking VFib junk on the right. So yes, so one shock, and I think like you said, it's a 200 joule shock, so I pretty much do that every time. I don't think I've ever shocked anybody with 120. So the big thing on the box is you have to charge before you shock. So that way you can't just press the button and zap somebody as they're doing compressions. So you have to charge, and it's gonna do this little like awkward sound. So everyone knows to get away from the patient like right before you shock.
Do you charge before you know the rhythm just to have it ready to go?
You can, but it's pretty quick. So I just pulse check, look at the rhythm, and then if it is that, charge and shock. Now as far as meds go, okay, let's say this scenario plays out, you shocked them, and then like 3 seconds later, it's just right back in VTAC, and you're like, oh God, all right, they don't have a pulse, we're doing compressions. What medicines can you give if you run into this situation?
Amio.
Hey, nice. All right, so yes, amio or lidocaine. The only thing to note, amio is by far the most common. So the dosing, a lot of times we give patients, if you ever give an amio push or bolus on the floor for like AFib or whatever, it's normally 150. The code algorithm is actually 300 for the first dose and then 150 if you have to repeat it. If you do this and it's just like refractory VTAC code, a cardiac patient that just had a STEMI, whatever, you can also give lidocaine. Lidocaine dosing comes in these 100 milligram ampules. Just push the whole thing. Regardless of patient size, dose, anything, just give them the whole 100. They're already dead. They're not going to be any more dead by giving them too much lidocaine. But the thing to remember on this, so in the code algorithm, it actually has you shock the patient twice for VTAC before giving medicines. My recommendation is if you see them in VTAC, go ahead and give them amio. Just do it, because they're going to get started on amio after the code if they live. So just go ahead and start it now. Maybe help them out. So you give them amio, and you shock them, and then you get to the next pulse check, and now they're still in VTAC, but somebody says, I have a pulse. Now what do we do?
This is the synchronized version.
Yes.
It's still technically unstable VTAC though, so just defibrillate.
So it is cardioversion. So if they, let's say if they have a pulse, so pulseless VTAC, you shock. If it's VTAC with a pulse, yes, cardiovert. So on the monitor, let me do it here. I'm sorry, this is a horrible picture, guys. I'm sorry. So yes, anytime before, if you were to shock, you hit this nice little charge button and you can select the energy or joules by this, and then you boop, shock there. Cardiovert has a little sync button right here. You press that before you charge and before you shock. And basically you'll see little arrows pop up here that'll come on every QRS complex. So that way, once you actually charge and hit shock, it delivers the shock on a QRS complex. Oh, there you go. Like I said, I told you I haven't looked at this in like a week. Okay.
So you gotta hit the sync before you charge.
Yes, yes. And that little light on the sync button right here will actually be flashing blue if you aren't looking up here above the QRS stuff. So you'll know that it's synced. I don't think it says it out loud, but
And do you have to have the little leads on to sync? Or can you do it on the pad?
just the pads. Yep. Any questions about that? Sorry, I know I'm just kind of like going through this, so y'all stop me if you need to. Okay. All right. I realize I did not set this slide correctly, so I'm gonna quiz y'all. Okay, so let's say you do this. We're now in our like 4th round of this code. They lost a pulse again, and you're like, why did this patient code? You have to go through the H's and T's. Do y'all remember what those are by chance? Just to like run like, okay, have we reversed reversible causes before we start telling the family we should DNR this patient?
Hypoxia,
Yes.
hypovolemia,
Yes.
H or acidemia.
Yes.
I'll defer the next to who wants us to go next.
Toxins.
Toxins. The other H was hypo or hyperkalemia.
Hyper, okay.
Is tamponade one?
Mm-hmm.
Tension,
Yeah.
Tamnod,
Thyroid? Something?
Hypoglycemia.
Thrombosis.
There you go. Yeah, I was gonna say T for thrombosis, whether it's in the heart or lungs. So yeah, that's just, I don't know from personal experience, if you get to this point in the code here, there are other people around. So I think what'll happen, and I can't remember if I have slides on this after this, so we'll just say it twice if I mess up, but a lot of times you'll get into a code and like 2 rounds in, you'll have like a pharmacist or a nurse be like, oh, do you want to give bicarb? Do you want to give calcium gluconate? Do you want to give insulin, D10? Like, and I'm like, I literally don't care. Unless they're like hyperkalemic and we had to reverse it, or you know they're super acidotic and that's why they coded, none of that stuff matters. So just keep that in the back of your mind as you go forth and crush it. Oh yeah, here we go. Yeah, should we get some sodium bicarb? I don't care. You just, whatever makes them happy, you give it to them. Okay, all right. Pulse check 4, we got ROSC, they're going to the ICU. Only other thing before kind of talking through unstable arrhythmias, airway team will come in. This is like, they really will like run in at UAB and like try and tube your patient in the middle of the code. Never stop compressions or let them dictate a code if you're running it. They can put the airway in on a pulse check or when they have time. You can always, but you can literally bag a patient until they get to the ICU and tube them there. Just as long as you have an airway, it's fine. It doesn't have to be advanced airway. Okay, so now you're on float and they come back out of the ICU like 3 days later and now they're on our service and you're cross covering and they paid you about a heart rate of 28. So what do you want to do with a heart rate of 28 now?
stable or unstable.
Yes.
Send them back to the unit.
Yes, I love that.
Probably already unstable, honestly, at that heart rate.
So, okay, well, let me ask you this. What would make someone unstable versus stable? Like, what would make you worried about that heart rate of 28? Because I feel like I ignore these all the time at night when patients resting comfortably in bed.
Yeah, cardiac output drops and you get end organ consequences because of that. So alter,
Yes.
hypotensive.
Yes. Yes. Lovely. Okay, so literally just the basic things. Get an EKG, maybe get some stat labs if you're worried about, whatever electrolyte disturbance. And then, yes, so are they stable? And then do I have to treat them? So the biggest things to look for, are they hypotensive? Are they altered? Are they having some end organ damage, chest pain, worsening CHF, whatever it may be? So, okay, bradycardia management. So the atropine dosing, This is typically as far as we can go on the floor. So some people will do 0.4, some people will do 1 milligram. I just do 1 milligram. You can do it times 3 doses, so 1 milligram every 5 minutes. It's like the equivalent of like Metote 5 IV. You can do every 5 minutes or whatever. Just do that with atropine. Now, the other thing to think about as they go forward, if you get started, dopamine and epinephrine drips are going to be the things that are like continual from a medicine standpoint, which luckily we don't have to deal with that. The other thing, just talking out loud, thinking about this, so if you get an EKG, just try and like really evaluate it to see if they have a heart block. That's the most concerning thing to look at when you have somebody bradycardic. Because if there is a heart block, just even if they are stable, page EP or cardiology. Questions on that?
Yeah, I guess, a lot of times at night, patients will get bradycardic and you wake them up and their heart rate goes back up.
Yes.
So obviously we don't really do anything with those, but people freak out about that all the time.
Yes. So like resting heart rates, because you have a higher vagal tone, is totally normal. Like I've even had people in like the high 20s where sometimes I'll get an EKG and sometimes I'll just tell the nurse like, hey, go wake them up. If it comes back up, tell them to go right back to bed. Totally normal. And honestly, like resting heart rates can be variable based off genetics and then like exercise capacity. So it's definitely not uncommon to have people just 20s and 30s every night. It's honestly more so just a number that scares the nurses than actual clinical situation. Okay, so let's say we've atropined this guy 3 times, heart rate's 35, and we're still working on getting EKG. What can we do next? Anything?
Pace them.
Yep, pace them. Okay, so there's 2 types of pacing. There's transcutaneous and there's transvenous. We can transcutaneously pace, pads in a normal position like you would during a code scenario. And then where the pacing component of this comes in is down here. So this little button, you hit pacer, and then this changes your rate right here up and down. Typically it starts at 60. You can pace them anywhere from 60 to 90 beats a minute. And then your current, and then pause is how you kind of stop and see if they have an underlying pulse. Now the biggest thing to think about pacing, so let's say you turn it on, their heart rate is 30. You start turning the rate up to say 80, and their heart rate is still showing 30 on the monitor. Like, why is it not working? So you have to turn the current up. It goes up by 10 milliamps every time you turn it up. And what you want to assume is you want 100% capture rate. So what that means is you want to look and see every time there's a pacer spike, there's a QRS behind it. Because you'll see as you start to turn it up, it'll pick up, maybe get like 50% beats, and then once you get to 100, you just keep it at that, so that way they get the most minimal amount of shock, but their heart is pacing like it's supposed to be.
And they feel that, don't they?
Oh yeah. Yeah, they can feel it. It's not like a shock or cardio version. It's much smaller, because this is milliamps versus whatever the hell joules to amps conversion is for a shot. Yeah, but yeah, you don't see their whole body like lock up with this. And it is okay. Like, this is the other thing. I always thought this was like, as a resident, I was scared to touch a patient who is being transcutaneously paced. You can like put your hand on the patient. You're not going to get shocked if they're transcutaneously paced. Vice versa. Don't do that during a code.
Thoughts on going up and then coming down to 100% versus starting low and then going up to 100%?
So it starts as like low. It's on 10 milliamps when you start. So you can just go up.
You don't ever start at max and then just go down until you lose capture?
Normally, just like in the limited patient experience I have, normally somewhere between 40 and 70 milliamps. And like I go up like quick. Like if it doesn't capture like on 1 or 2 beats, like I'm going up every time. So honestly, in the span of like probably 10 seconds, you can get up to 100% capture. Yeah. And then be nice. If they can tolerate it, great. If not, maybe give them a little Versed or something in this situation, because they do feel this, even though it is kind of smaller shocks. Okay. You fix their bradycardia. Now the next night, you get a call about a heart rate of 178. So now what do we do? This guy's just a cardiac bomb, clearly.
I think hospice.
yeah, honestly.
I mean, we just gotta figure out if it's stable or unstable again.
That's right. Same criteria for stable, unstable, different.
Same criteria.
Okay. Lovely. Okay. Yep. Absolutely. Same criteria for stable, unstable. Probably try and get an EKG as quick as you can. Stat labs, vitals. Yep. So same exact stuff. So, all right. What do we want to do if it's unstable? And but by unstable, let's just imagine this patient they were fine, and maybe they have a history of AFib, went into some type of SVT, can't really tell if it's AFib, it's so fast, their pressure is like 80/50 now, and they're like diaphoretic and pale.
Energy. Yes. Regular.
Yes. So definite, so unstable basically equals cardioversion when it comes to SVT. Especially with hypotension, because any medicine you give that reverses this is going to cause hypotension, metoprolol, DIL, whatever. Amia may be the only one that doesn't really affect the pressure. So, yes, this one, I guess it's a little clearer picture. Yep. So this one, sync, charge, boom. Okay. So, all right. Other scenario with stable-ish SVTs, and what I mean is like, say this same patient, except they have a pressure of like 100/60. They don't look like death warmed over, but meemaw just don't look right. Like she could look a little better. So when you're getting your EKG, is it wide complex tachycardia or is it narrow complex? Most typically, you're going to get a narrow complex tachycardia, whether it be AFib or SVT from whatever other source. So if it's regular and narrow, the first thing you can always do is try a vagal maneuver, have it bear down, try and blow in a little, what are those things called, like a syringe. And then you can do adenosine. My only experience here with adenosine is you have to have the med team there. You got to have good IV access, and you got to have a continually running EKG to assess. So you can do 3 doses, 6 milligrams, 6 milligrams, 12 milligram. Patients feel like crap when you give them adenosine because essentially their heart just stops for a couple seconds, and it's a little scary experience for them. But you always have to have the pads in place because they can, when you give adenosine, it's extremely rare, but they can go into like a ventricular arrhythmia that does require a shock. Most commonly, if you just get AFib RVR or SVT and they're like blood pressure is fine, beta blocker, calcium channel blocker, so literally metope or DIL, just whatever, and they're probably fine. Only other thing to note on a wide complex. So if you have a stable-ish wide complex SVT or tachycardia, it's good to know what the prior EKG looked like, because if they have a underlying left bundle branch block, you're going to look at that and be like, oh crap, they're in VTAC, when really they're in SVT, but they just have a left bundle. So, and it's not great to shock those or defibrillate those. If you did that on accident, it just gets squirrely. So, if it's wide and regular, if it's wide and irregular, then that's either polymorphic VT or AFib with bundle branch block. So if it's regular, like looks like stable VT, you can do adenosine. So that's the only other thing you can do if you want to slow it down and look at it a little bit more to get an EKG. And then antiarrhythmic, if it's wide, you can always give amio, and there's no harm, no foul, because amio will treat AFib with RVR, it will treat VTAC, it will treat everything. So amio's your friend, 150 bolus, call cards. Questions on that? I feel like that was not a well put together slide.
I feel like a lot of these I've been to, we end up, I mean, their pressure may be like in the 80s, but we end up like going for some adenosine before we, I don't know, like.
Just to slow them down and see.
Yeah, a
Honestly,
lot of
they'll
times that's
break.
what it ends up being, and it's like, oh, they're actually an AFib.
For a transplant eval, you know, because he was having like some sort of episode. So
Wait,
She
what?
forgot to mute.
Okay.
She's on lung transplant.
Ah,
Yeah, I had a ER guy say, you'll never get in trouble for treating, SB2 with average or Y complex with electricity, especially if they're like maybe a little tenuous.
yep, never wrong for cardioversion or amio. You can't go wrong with those things.
You get him out of ETAC, you're the hero. You shock someone with not, but
Yeah.
still.
Okay, as I promised, I'll try to keep this short. The biggest things, so for us that's useful, you show up to a code, 2-minute drill, make sure that they're actually given halfway decent compressions and you've given epi, and then basically just set yourself up for success. Assuming that no one's coming to help you practice under that protocol, but the med team will be there for you at some point. If you ever get to the point where you're running a code for a long enough time where you have time to consider your H's and T's, I think one thing is somebody who might be in the situation of running a code. If you're the primary person caring for the patient, honestly, one of the most useful things you can do is actually just give information, lab information to the med team when they show up to help them kind of figure out a pathway to go down to work up or reverse any underlying cause. And then just remember, if you ever go to a code, don't ever hold it against yourself if you don't consider, if you don't get the patient back. It's not like a loss or a bad outcome. The mortality rate, I think when I was in residency for in-hospital PEA arrest was 96% or something. So I mean, you're looking at 5% of people you get back from a PEA code. PEA codes are the absolute worst, they're the devil. VTAC codes are much better because you can fix something going on. Yeah, okay. Wow, that was quick, okay. Does anybody, I just felt like I just kind of went through that real quick. Has anybody got any questions or certain examples or situational questions, anything?
I heard that the average number of ribs broken during a code is 7, so you really should be breaking ribs.
Love that.
I guess when you're cardioverting someone that's actually semi-awake,
Yes,
obviously I know it's gonna hurt. What meds do you typically give?
that's a great question. So if they are dire straits, their pressure is 60 over death, there's no time to give them meds. I don't. Now, if it is, you have time, crash cart's there, a lot of times I'll do Versed, just push for a Versed. If you want to do Versed and maybe a little bit of Dilaudid for pain, I feel like Versed works better because it just kind of puts them a little more out of it and it doesn't crump their pressure like Dilaudid or a stronger pain medicine would. Yeah. But they will feel it.
Oh yeah.
They will feel it.
That's the problem with dying. It's kinds of things we do to bring you back around.